So in this lesson here, we will be going over the entire complete cardiovascular assessment, heart sounds, cardiac devices, and advanced hemodynamic monitoring and common labs. All right, starting with vitals and trends, you always want to check and confirm the vital sign goals with the MD. Oftentimes they are in the order sets within the electronic MAR. And you really want to know your previous trends to know where you are and how far off you are from your patient's baseline. Starting with telemetry, you want to note the rate, regularity, rhythm, and if there is ectopy present. If there is ectopy present, you do want to know if it's very frequent or if they're having patterns, things like bigem, trigem. You also want to look into the recent EKG. So when you're looking at this patient's telemetry, you want to note if they have a P wave present and consistent with every QRS complex. Note if the QRS complex is wide or narrow. Look at their T wave for any abnormalities. Also assess for any ST elevation or depression. And then also we like to monitor our QTC. We will get into why later in this module. You also want to see if there's a presence of first degree blocks, bundle branch blocks, second degree blocks, and complete blocks. This all has to do with the measurement based on your P waves and your QRS complex. Ectopy, different examples of that are PACs, PVCs, and PJCs. So these are preatrial contractions, preventricular contractions, and then pre-junctional contractions. So make sure that you are able to know the difference between these three things. Again, noting the patterns, if they are there, bigem, trigem, or quadgem, and if they are actually perfusing these beats. In order to mitigate ectopy, you want to make sure you are optimizing you want to know their current electrolytes and if their electrolytes are currently optimized. Usually we can just throw them on the ICU electrolyte protocol if that's something your facility does. Then we are going to talk about blood pressure here. Is your A-line and your blood pressure cuff correlating? Are they in between anywhere from 15 to 20 milligrams of mercury together? Is your pulse pressure wide or narrow? Moving into heart sounds, we have our S1 or S2 and the extra heart sounds. Note the intensity. It's good to know if your patient's heart is dim or not in order to keep track of something called a cardiac tamponade. Adventitious heart sounds are murmurs, clicks, and friction rubs. A great resource for heart sounds and murmurs are right there. I'll be sure to add that link onto the Facebook page as well. You want to look at their skin, the color and temperature. Are they pretty diaphoretic or are they actually cool and dry? Check for cap refill. We all know that normal is less than 3. We also want to assess for edema. We want to make sure that their right and left arm and right and left leg and right leg are symmetrical. If they are not, you need to assess for something called a DVT or some kind of thrombosis within one of those limbs. Moving on to pulses. So again, this also goes in with the DVT. You want to look to see the amplitude and quality. If you do have issues finding pulses on the feet, either pedal or pulse tib, you can mark these with a skin pen, and then you can go back and use your Doppler just to make sure you were able to find those pulses quickly when you are doing your assessments. So again, make sure that the edema and pulses are equal and bilateral for all extremities involved. Moving into left versus right ventricular failure. For left ventricular failure, you can have an S3 heart sound for a non-compliant ventricle. The PMI is moved often due to left ventricular hypertrophy or because the heart is working so hard that left ventricle can get too big. So therefore it shifts it away from the usual spot it is when you're listening to heart sounds. And then there can be fluid or crackles within when you're listening to that patient's lungs, just because of the backup of fluid, because of the non-compliant left ventricle. All right, moving on to right ventricular heart failure, you will have something called JVD or jugular vein distension, I should say. Then you want to look for peripheral edema. You want to look at the lower extremities and upper extremities. And then there's something called hepatojugular reflux, which is an assessment mechanism that some physicians do. I haven't actually seen it done within my critical care world, but this is when someone pushes on the liver for about a minute, and then when your patient is laying back, you can see jugular vein distension, and then depending on after you've released the pressure on the patient's liver, how fast that the person releases that JVD is dependent on how functional their right ventricle is in removing that extra fluid load. All right, so this is a little introduction to your stethoscope. We all know how stethoscope works, but it actually means and literally means to look at the chest. So you have two listening modes. You have the bell and the diaphragm. So the bell is good for low pitches and for good stenosis murmurs, and the diaphragm is good for high pitches or the rest of the majority sounds of the heart. So the normal heart sounds are lub, dub. S1 is lub, and which accounts for systole, which is the third or the first third of the cardiac cycle. S2 is the dub or the diastole, which is this other 2/3 of the cardiac cycle. So you want to auscultate for rate and regularity, and also check if this is consistent with the monitor. Then you are going to monitor for abnormal heart sounds or the adventitious heart sounds. So these are murmurs, clicks, and extra sounds. So for murmurs, you have the aortic and pulmonary regurg. For these, use the diaphragm. Then you want to listen for AV valve stenosis. For that, you can use the bell. Again, clicks and then extra sounds here. And then for the S3 and S4 sounds, you can use the bell. So when you're listening to your patient's heart sounds, make sure you're doing it without distractions. Don't be afraid to remind the patient to take nice, slow, deep breaths, or ask them kindly to not speak. Sometimes you get into a patient's room, you're trying to do your assessment and listen to heart and lung sounds, and your patient just keeps talking. So just ask them nicely, or if their loved one is trying to speak to them during that time. Definitely don't be afraid to ask for what you need in order to assess your patient correctly. You can also mute the TV. What was also helpful for some people is to close their eyes and watch the monitor as they are listening to the heart sounds. All right, so extra heart sounds, these are your S3 and your S4. The S3 is a ventricular gallop. So you listen to this over the apex area. So this is from blood hitting the ventricle. It sounds like Kentucky. So Kentucky, 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 Kentucky. So this is abnormal, and it does indicate fluid overload. So your preload is usually up when you have an S3 heart sound. So the S4 heart sound is the atrial gallop. This is presystolic. So it's S4, S1, and then S2. It's vibration. It sounds like Tennessee, Tennessee, Tennessee. So this is abnormal, and this is caused from increased resistance to ventricular filling. Okay, so friction rub is caused by the pericardium or the heart sac being inflamed, or that's also called pericarditis. There are many causes after in MI, tuberculosis, post-cardiac surgery. So pericarditis does cause diffuse ST elevation across all 12 leads. So if you are concerned about ST elevation, always get an EKG so you can rule out pericarditis to see if there's actually an acute blockage going on at that time with your patient. For all cardiac devices and advanced hemodynamic monitoring, you want to make sure that all the devices are patented, all the dressings are secure on your central lines, peripheral lines, and invasive monitoring devices. Make sure that these devices are accessible to you and aren't tucked back or underneath them, so that you are able to zero them or access them, or to monkey around with them easily. So the devices that we will be going over are the pacemaker, external PA catheter or the Swan-Ganz line, and then the EV1000. Okay, so this is a picture of a temporary pacemaker right here. This is a pacer box. So you have your pacer box with A and or V wires, depending on what epicardial wires your patient has placed into them. All right, so you will have different settings depending on the wires you have. So if you just have A wires, then you can only pace via the atrium. So then your settings will always start with an A. If you only have ventricular pacing or V wires, then the first letter of your setting will start with a V. But if you have A and V wires and you are AV pacing, then you will usually be in a DDD setting. So the first letter of the mode is the chamber that is paced. The second letter of that mode is the chamber that is sensed. And then the third letter of that mode is a response to the sense event. So D means dual chambers, A is the atrium, V is the ventricles, I means inhibit, T is trigger, and then O is none. So the common modes we most often see within our own ICU are DDD and BBI. So again, we are going to first letter, we are going to pace both of the chambers. Then we will sense both of the chambers, and then we will both inhibit and trigger a response to a sensed event, depending on what the pacemaker thinks that the patient currently needs. VBI, so this is, we are going to be ventricularly pacing, then ventricularly sensing, and then inhibiting response to a sensed event. So there's many different concepts and modes and parameters. You have your rate, which is obviously the rate which is what you want your heart rate to be going on the pacer. Then you have your voltage or the output, and then you have your sensitivity. So there's a lot more that goes into these pacemakers aside from just this one slide. But just be sure whenever you have the opportunity within your own facility to get your hands on one of these, even if you're just with one of your experienced nurses, make sure it's not connected to the patient, but kind of play around with the rate and the voltage and the sensitivity. Always remember that sensitivity, when you're adjusting sensitivity, think of sensitivity as a fence. You want to be able to view past the fence to look at the underlying rhythm, because if the fence is too high or if your sensitivity is too high, or isn't, so it's always opposite. So if your sensitivity is high, you are not going to be able to, so if the sensitivity voltage is high, you will not be able to see your intrinsic rhythm. So therefore your fence is too high, so you can't see what's happening behind the actual fence. So what's happening behind the fence is that patient's intrinsic rhythm. So you want the pacer to be just sensitive enough or at the right millivolts to be able to sense the intrinsic rhythm, so that you aren't sending weird pacer spikes where you shouldn't, which is on the T wave. Pulmonary artery catheters, also called Swan-Ganz lines. So these monitor pulmonary artery pressures. There's many different types, which are the VIP, which have an extra port for infusing medications, pacing. So you can have PA catheters that can actually pace, and then you have some that can actually provide continuous SVO2 monitoring as well. So you really want to be able to identify the appropriate waveforms on these. So the waveforms are able to tell you the location or if your pulmonary artery catheter is wedging. Normal PA pressures are quarters over dimes, and you can shoot your advanced cardiac numbers. So you might hear something called, oh, we need you to shoot numbers. So this is talking about injecting off the D5 port there to get your advanced hemodynamic monitoring numbers like your SPR, your cardiac input, your cardiac output, things like that. So there's many key safety points here. So you want to make sure that the balloon is deflated, locked out, and with the right syringe. Make sure that the device is secured and can't be pulled out. Again, because this device is literally sitting right in your pulmonary artery. So if this gets pulled out, you can tickle your ventricle with the pulmonary artery catheter, and you can send your patient to some not so fun or lethal heart rhythms. And then again, make sure that these are in the correct place on the X-ray. And you can look at this with an experienced RN, NP, or MD. So here's a picture of so depending on where this pulmonary artery catheter is, this will dictate the waveform. So you can see, when you have a physician floating a Swan-Ganz line, so you will have the monitor on a specific setting, so you can really see the PA waveform. Most of our monitors have them, so it basically magnifies the PA waveform so the physician can see. So when you're first going into the right atrium, you have low pressures there, as you see on the left, and then you move into the right ventricle. This is when you see your numbers where they are there, 20s to 30s, and a low diastolic number. And then when you're right in the pulmonary artery, this is when you see your quarters over dimes. So your systolic pressures are 20s to 30s, and diastolics are 8 to 15. And then you'll see your wedge pressures here over on the far right. So this means that the balloon on the end or the tip of this catheter is inflated, and you're checking that wedge pressure right there. So again, note that depending on where this catheter is within the heart ventricles and in the pulmonary artery, and whether or not it's wedged, this will dictate the waveform. So make sure you are aware of what the waveforms are when you're monitoring your Swan-Ganz line. Okay, so here's a bigger picture of the Swan-Ganz line here on the right, and then where it sits in the patient on the left. So again, so the Swan-Ganz lines are typically yellow, and then you have your balloon port, you have your CVP port, you have your cardiac output indicator there as well. So just be sure you know what type of pulmonary artery catheter you are dealing with, and make sure that you are infusing these medications into the right port. There are some ports you cannot use, so again, just be sure you are asking an experienced RN who is with you at the bedside, or your education department to provide further information on the specific pulmonary artery catheters that your facility uses. Here's just a little bit of a picture and a diagram of how the thermodilution technique works with the D5. So basically you inject a certain amount of the dextrose solution into the heart, and then based on the cardiac cycle and the algorithm within our monitors, it's able to shoot or to provide us an area under a curve, and then the area under the curve then will represent other numbers, which are our cardiac output, cardiac index, SVR, and all those fun advanced hemodynamic numbers that we need in order to safely and appropriately titrate those medications that we're infusing into our patient. All right, so this is the EV-1000. So this is, again, advanced hemodynamics. This is non-invasive. So this uses the existing CVP and arterial line. So the simple way to look at this is that every single number on here typically is talking about contractility, preload, or your afterload. And the complicated side of this, you can get into volume status, cardiac output, cardiac index, SVR, SI, and extra long water, or some other advanced pulmonary monitoring for some very sick ARDS patients. But for the purpose of this course, we will just be focusing on the relatively simple aspects of these machines. And then something else to note is that if your patient is in AFib, the algorithms of this machine don't work. So you can use them for things like SVV, but you won't be able to get the other numbers from it off of that. So here's a good diagram about the complexity and how everything is basically related for your hemodynamic principles. So your cardiac output, so if you look down at the bottom here, your cardiac output equals your heart rate times your stroke volume. And you can kind of move up and see how everything actually affects everything. So everything in here is very closely related, and that's why it's very important to know how and what and why these things work together. So here's an example of one of the screens of the EV-1000. So again, everything on here is pretty complicated, but almost all of these numbers will indicate preload, afterload, or contractility, or your fluid status, which is, again, a good indicator of your preload, right? So when you're looking at your cardiac index here, so this right here is your cardiac index. So that has to do with your contractility, your SVV, this is your stroke volume variance. This has to do with the variance in the stroke volume. If you have too much variance in your stroke volume, this means every subsequent beat you are having, it has a high percentage variable, which means your patient is dry. High SVV means your patient is dry. If your patient has a lower number of SVV, then that means there is less variance with every single stroke volume that is being given from your patient's heart. So therefore, they have a more consistent and adequate and appropriate volume status. Here's another review or option of a view for the EV-1000 as well. Kind of breaks things down. Again, some of these things down here we don't always use. But everything can be broken down into, again, preload, contractility, and afterload. Here's another picture. So this screen right here is typically what we are used to seeing within our facility, and this gives us a better picture about what's going on with a little bit easier parameters to use to titrate our medications. So just be aware there are many different settings and pictures and screens on these. Just make sure if you have to use this for your patient that you are utilizing the screen that makes the most sense to you. I often have mine set on this one or on another one, which has, I think, 6 gauges on it. So then you can watch things just as they are. But the screen here is pretty cool too, just because you can see. So if your patient has has a high or low SVR, it will either constrict or vasodilate here. So it's pretty cool. So it will literally show you exactly what's happening within your patient. And then here's kind of a picture of the setup. So these are very interesting to set up. So I recommend downloading the Edwards Life Science app. It actually has videos on there as far as how to set this up for you. So common cardiac labs are your electrolytes. These have to do with how the electrical conductivity within the heart works, your CBC, your coags, your lipid profiles, your cardiac enzymes, and then drug level. So pertinent ones for here would be your digoxin level. And again, we will go over all these labs in a subsequent module.